Good evening, professors and colleagues. It's Mona Hussein from Theodore Bilhars Research Institute, Egypt. During reporting the MRI cases of the perianal fistula, I noticed the interredal variabilities and increased missing information between reports. Do you think is it easy to standardize MRI reports to help both radiologist and surgeon? Let's get to know. As known, MRI is extremely helpful in diagnosing the perianal fistulas. The structured reporting is a simple template containing key descriptors which help proper characterization of the perianal fistulas, proper surgical management, and monitors treatment response. It aims to increase completeness of reports, decrease missing information, and interredal variabilities. So the aim of our study is to assess the added value of the structured reporting over the conventional reporting in the characterization of the anal fistula by MRI and its impact on surgical management. The important anatomical spots are: on coronal images, characteristic tube within a tube configuration of the sphincteric complex can be seen. The inner tube is the internal anal sphincter. It's bounded laterally by a very thin hypointense muscle layer called the longitudinal ligament. The outer tube is the external anal sphincter formed of deep superficial and subcutaneous parts. It extends up as a puborectalis, fans up as a levator ani muscles of the pelvic floor. The important intersphincteric plane is a thin layer of fat plane lies in between the longitudinal muscle and the external anal sphincter. On the axial images, on the zoomed image, we can see the intersphincteric plane defined as blue asterisk in a space between the hypointense longitudinal muscle layer and the external anal sphincter. At a higher level, puborectalis is a strong U-shaped muscle encircles the anorectal junction, and the levator ani level, the iliococcygeus muscle converges posteriorly to insert into the anacoccygeal raphe and coccyx. Our observational study on 60 adult patients diagnosed with perianal fistulas, reported conventionally, and then retrospectively reassessed using a template composed of 8 key descriptors, and a radiologist assessed the presence of descriptors in the conventional reports and compared them to the structured report. T2-weighted images is very important for detailed anatomy. Stair and T1 contrast images is important for detailed pathology and fistula delineation. T1 alone is far from giving enough information, and multiplanar assessment is important. This is a proposed template. It's super easy and simple, as suggested by Sodel et al. It's formed of 8 key descriptors. First, for the primary tract, Parkes type takes into account the course of the fistula in relation to the sphincteric complex. The intersphincteric fistula is the most common, and it lies within the intersphincteric plane. Colloquial localization specifies the hour at which fistula relates to an anatomical structure or to the sphincteric complex. Height of the fistula as low or high, diameter, maximum cross-section dimension, secondary extension, their Parkes classification for each, colloquial localization for each, and their number is important. Internal opening, whether closed or patent, their number and location on colloquial, abscess formation, their anatomical location and colloquial localization, and also the amount of the affected sphincters and the sphincter morphology. As known, fistula affects male more than females. Percentage of the missed finding in the conventional reports when compared to the structured reports were: conventional reports missed commenting on 70–80% of cases on patency of the internal opening, followed by diameter of the primary tract, followed by height of the primary tract, and so on, with a significant difference between the conventional reports and structured reports in the missed findings. Proper characterization affects surgical planning. It helps achieve complete remission, help procedure selection, and predict continence outcome, reduce the recurrence, and satisfying outcome. This is the case of a complex fistula. Let's report it together structurally. As we see, it's a right lateral fistula tract opposite 8 o'clock position. Its high tract reaching the level of puborectalis of a maximum cross-sectional dimension of 7 millimeters. Its intersphincteric pierces both internal and external anal sphincter. It opens posteriorly by a single patent opening opposite 6 o'clock position, associated with a horseshoe collection within the intersphincteric plane, extends from 4 to 8 o'clock posteriorly. Two side branches, one is posterior supraelevated opposite 6 o'clock position, and another is on the left lateral aspect opposite 5 o'clock position. The sphincteric morphology, we can see edema affecting the right side of the external anal plane, extends for about 40% from 1 to 6 o'clock position. This case shows a missed posterior transsphincteric secondary branch on conventional reporting. This is the posterior branch who is missed on conventional reporting. Follow-up of this case show progression of this branch into a collection. This case show a pre-surgical high agreement between conventional and structured reporting with a favorable post-surgical outcome, indicated by healing of the primary tract. 30 seconds. Healing of the primary tract and regression of the collection. Conclusion. Structural reporting increased completeness of reports and accuracy of diagnosis, reduced missing information and inter-reader variability, help precise surgical planning and post-surgical recurrence. It's also provide key descriptors to surgeons. Details make difference. Thank you.
Any question?
Sorry, أنا خلصت ماشية. Thank you.
Thank you, Dr. Amon. خلاص, thank you.
Okay.
Next speaker, Dr.